Good afternoon, everybody, and welcome to today's webinar series. My name is Dr. Jeffrey, and I'll be your host for today's webinar session. So today we'll be having a presentation from Dr. Nneka Okafo. She's the medical officer at eClinic and Diagnostic Center here in Usetu, Abuja. And she'll be talking to us on cervical cancer, the myths exposed. She'll be giving us 15 minutes lecture on cervical cancer. Thereafter, we'll have 15 minutes question and answer session with her. And then we'll give 2 minutes conclusion from her and we'll draw the curtains for today's presentation. So once again, we're all welcome to today's webinar session. And without taking much time, Dr. Nneka, it's over to you. You can start your presentation. Thank you.
Thank you very much, Dr. Jeffrey, for introducing me. Good afternoon to all our participants. You're welcome to today's webinar on cervical cancer. This is February, the month of Cancer Awareness Month. But for the benefit of this webinar, we're going to be focused just on cervical cancer. And now we're going to start it properly. So cervical cancer, I can and I will. This is the theme for this year's cervical cancer team all over the world, and we'll be talking now about it. So for our table of contents, how we are going to talk about this cancer, we're going to introduce it, we're going to talk about the myths about it, we are going to talk about the causes of the cervical cancer, we're going to talk about the demography, which people, who is affected, we're going to talk about the risk factors of cervical cancer. We're going to talk about the signs and symptoms. When someone has this cancer, what happens? How is this person going to know that he or she has it? We're going to talk about the investigations. What investigations will this patient do to know exactly what's going on? We are going to talk about the treatment. If someone eventually gets cervical cancer, how can this patient be treated? Before we get to the treatment, how can it be prevented? We don't want it to come at all. So how do we prevent it from coming? And then we conclude. So we start now to ask about the myths. Myths are just basic hypothetical things people have in their minds about things. And we're going to be looking at some of the myths people have about this particular cancer. Some people will say, I don't need to get screened because cervical cancer runs in my family. So therefore, I almost assume that I'll have it. Another would say, I don't need to get screened because I don't have any symptoms. Some other women may say that cervical cancer cannot be prevented, so they might as well live their lives anyhow they want to. For some, they would feel that all women would need to do a yearly pap test to screen for cervical cancer. For others, they would say older women don't need cancer screenings, or that women who have gotten the HPV vaccine don't need pap tests. The question we are going to ask ourselves now is this true? Join me, follow me on this journey so that we'll be able to debunk most of them. So what is cervical cancer? This is the most common cancer we find in women all over the world. We'll be wondering where the cervix is. It's the opening of the uterus that we can't see because it's been shielded inside the vagina. There are so many cancers that women suffer, the cervical, the breast, ovarian, and endometrial. But we've seen statistics have shown that all over the years, the cervical cancer has taken precedence even over the breast cancer. So you now question how does cancer happen? What exactly happens? What exactly does it entail? Cancers are formed by the normal cells and tissues in the body. But because normally when cells outgrow what they're supposed to do in the body has a system whereby they just die off. But these cancer cells are either the new cells are formed when the body does not need them, or the old or damaged cells that are there already, they now don't die as they should. They now keep on growing and proliferating more than they ought to. That constitutes a cancer. What will cause this cervical cancer that we've heard so much about? Most of it are caused by human papilloma virus, which is a kind of DNA virus that is sexually transmitted. It has many types from 1, 3, 5, 6, 11, 18, 53, 57, 63, but we are going to concern about with the ones that are just highly oncogenic, the ones that will cause cancer. The most common strains we've seen 6, 11, 16, and 18. But another one, type 31, 33, has also been shown to be coming up and also has a causative form for this particular cervical cancer. Now, we have to note that type 6, this is how this cancer will look like when it starts happening in a female. A normal cervix should look this way. Then by the time it starts growing, we have what we call cervical intraepithelial lesions. It will just start growing. It won't just move from normal to cancer immediately. It will go through these phases. And because the time frame by which it will go through these phases is between 10 to about 15 years before it will eventually go from normal to this extreme of the cervical cancer. I have to reiterate something on these types. The HPV type 6 and 11, they're going to cause tumors, but these tumors are benign in that the lesions that they will cause are not cancer. There is majorly the genital warts that it causes. The ones that will give us the full-blown cancer after staying for so long is the type 16 and the type 18, which we are more concerned about. Now, this is how a cervix looks when it's cancerous. Now, the epidemiology. How many people eventually acquire this virus annually? That is in a year. Statistics have shown that in 1 year, about 500,000 women acquire this virus. It has also shown that the age range of affected women is women of between 35 to 44 years. Women younger than 35 is very rare for you to see them have this cancer. Now, we have to know that the older a woman gets, the higher her chances of getting this cancer. It actually increases. From this period now, most of them that have had this indolent virus in them, from here you'll be seeing their intraepithelial lesions, 1, types 2. By the time they'll be going into their 45, 50, 55, you now see everything becoming full blown. It's not surprising that this number of people that acquire this virus, we get it from developing countries like ours. Why is it so? It's because part of our problems here, infrastructure, development, and the rest of them, poverty, people not coming to the hospital to get screened, people will just allow themselves, they'll move forward until eventually there's a problem and they can't do anything about it. So developing countries actually have a high rate of incidence of this cancer, and about 500,000 equally die of this virus annually. So it doesn't mean that it's the ones who acquire it that will die. For those of them that have died, that means they've gotten it long before, maybe probably in their middle ages and all. Now we move forward to talk about the risk factors. What are the risks associated with this HPV? Remember that we said in the beginning that HPV is sexually transmitted. And by the time from 9 to 13, we assume that people have not yet become sexually active. But from that age and above, by the time children go to secondary school, enter the universities, it's expected that most of them become sexually active. And by the time you take male, a typical male, yes, that has undergone through gone through puberty, has become sexually active, will notice that the number of their sexual partners would increase as the years go by. And between 80 to 85% of people that are sexually active must have had HPV at some point in their life. So the higher the number of sexual partners one has, the greater the chances that this person has already contracted this particular virus. A family history of cervical cancer, if a mother or a first degree relative has cervical cancer, there's an 80 to 90% chance that the females following would have this cancer if care is not taken. A weak immune system too can cause this cervical cancer. Now, when people are strongly immune and they contract this virus, what happens is that they'll stay in the body, and after a year or two, the body fights it so much and kills it and knocks it off, and the person becomes free. But when someone's immune system is already down, this person is unable to fight this virus. Majorly if the person has any chronic disease of the liver, chronic disease, of the kidneys, or people with HIV, hepatitis B, and the rest of them, they could have this HPV. Smoking has equally been shown to have a direct link to people having cervical cancer. Prolonged use of contraceptives. The more someone uses contraceptives, especially COCPs, the combined oral contraceptives, the greater the risk or the chance that this person would eventually contract cervical cancer. DES is what we call diethylstilbestrol. Now, this is a drug that was used around the 1940s to 1960s as a means of contraception. It has been shown that for ladies that used this back then, that there's a higher chance of them getting this cervical cancer than those that don't have it. Then lack of regular screening. Remember we said that cervical cancer will not just start happening immediately. For someone to come down with cancer, that means over the years, this person has had this cancer going on, but without knowing. So the more frequent someone screens, the earlier it will be detected and treated. So for people that don't do it, they are at more risk of having this cancer. Now, when someone has cervical cancer, how will it present? It could be asymptomatic. That means you're not going to see any symptoms. The person will just be fine walking about. Or it could be symptomatic. That means there is symptoms seen. In the early stages, the person will not really notice anything. But as it progresses, the person can start having vaginal bleeding, will start bleeding from her vagina. This bleeding will be irregular. It won't be coming as normal as her menses has been coming. It could be intermenstrual, which means that if this person knows that on the 18th of a month, between the 18th and 24th of a month, I should see my menses. The patient will get it, the flow then, and maybe towards the 30th, it will start all over again. After sex, which is postcoital, this patient can equally bleed from the friction there because the cervix will become very friable. That means it will bleed easily. And it could equally be post-menopausal, which means after menopause. Remember, we said something about the age range. Immediately after menopause, as a woman is going into her 50s, 60s, she will now start bleeding. She has already stopped bleeding, then all of a sudden she will start bleeding. It is a sign that something sinister is happening. There could be vaginal discharge that is much and really smelly. The patient will start feeling unwell. She'll just won't know what's wrong with her, but she knows that her body is not as it used to be. Sometimes when she's urinating, she'll find pus inside the urine, and she could be urinating more frequently than she used to, could be having urge to urinate more frequently than how she ordinarily would. Then there'll be rectal symptoms. This is from the anus, if there's any mass symptoms, if this cancer has spread, and there will be pain. This patient will be feeling a pelvic pain during sexual activity, and if there is backache, the back will be paining the patient. Now, when someone has this, how do we investigate to know how to help this patient? We'll do a pap smear. Depending on what we see on the pap smear, we'll move further into colposcopy and cervical biopsy to send the sample for histology. This is the three of them. And afterwards, what is a cervical smear? This is exactly how it looks like. For this cervical smear, what happens is we'll use this. These are what we call speculum. We use it to open up the vaginal wall. This is a plastic one, and this is a metallic one. This is a cyto brush. So when we use this, we open the vagina, it will expose it this way. This is someone, a lady lying down as if she wants to give birth. We'll use this and open up. Then we'll use this cyto brush, go inside and take some samples. When we take it, we put it in this is the liquid base. We put it inside and shake it and now spread the cells we get under the microscope to know what kind of cells we have there. Now, if we find anything abnormal in the previous slide, we'll move further by doing a colposcopy. This is where we use this very long instrument. We pass it into the vagina of a lady, and then we look in with that lens to know exactly what you're going to see. If we notice any abnormalities, that is when we'll now eventually take samples for biopsy. We open up and then we use this, we take a pinch of tissue and send it for biopsy. Now, after doing this, this is what it looks like when a cervix is diseased. A normal cervix should look like this. Then by the time it starts increasing, this is how it will look like. The cancer starts coming, then it starts spreading. As you're seeing this, it's already becoming invasive, going up towards the uterus, the lateral pelvic walls, and the rest of them. So, how do we manage cervical cancer patients? When people now have cervical cancer full blown, how do we manage them? By surgery? We do surgery, or we use radiation therapy, just like how when we send people to come and do x-ray, just almost exactly that same procedure, but that one is now treatment, not diagnostic. And we use drugs that can kill off the cancer cells, chemotherapy. We could either do any of these or we combine these methods. And whichever option we're going to choose will depend on the size of the tumor. Is it small? Is it big? Has it spread? And then whether the woman would equally want to still be pregnant or not. This is for the surgery, we could take out some parts of the cervix, the vagina, or the lymph nodes, or we could take out the cervix and the uterus itself, or just take out some parts, or we take out the ones that will take off both fallopian tubes and ovaries and the lymph nodes. We could equally, for people that have CIN, that's what we call the cervical intraepithelial lesion, like this. It has not become full blown cancer. How we can help them is by doing this: lip or laser, cryotherapy, cone biopsy, or hysterectomy. In the laser, we can use light. For this one, we use a wire loop to sort it out. Cryotherapy, we'll use something like a gas that will go and knock off those cells and destroy it. Then for hysterectomy, we'll take out the uterus completely, or we leave some, or we take out everything. Then how can we prevent it? The prevention of cervical cancer is where everybody, every medical practitioner is going to. We don't want our people to have this cancer in the first place. So how do we prevent it? We have the primary strategy, we have the secondary strategy, and then we have the tertiary strategy. The primary strategy is basically for ladies from at least 9 to 13. We want to give them their HPV vaccine before they even become sexually active or before they even start making out with anybody. It's at this age that we target them and we give them their vaccines. Now, apart from these ladies, the optimal age is from that 9 to 13. We could equally extend it to 13 to 18 or and equally to 19 to 26 years of age. The older a lady gets, it's assumed that she's gone through some multiple sexual partners. And if she has, and any of them has HPV, there's a 90% chance that all of them must have gotten it. And because this HPV, we expect it to at least die after between 1 to 2 years. What usually happens is that they will start developing some degree of antibody against it. Vaccination is to help that antibody be developed before the person even gets infected. But if the person has already had it, then there is no need for them to now get vaccinated. That's why we stop at least this says 19 to 26, but we give some countries give up to 27 years. That's when they stop the vaccination completely. And then as from that 27 and above, you don't bother vaccinating them. You now target their 3 yearly screening to make sure that even if they have the HPV, that they're not developing any cancerous lesions. Prevention is better than cure is a saying that we've always known. So of the 100 types of the HPV, the ones that are known to cause cancer, the high risk ones, the 16 and the 18, we have vaccines for them. We have Tecarasil. This one will protect against the types of HPV that will cause both the benign and the malignant tumors. And the Severis, this one will protect against the one that will cause the HPV 16 and 18, the one that will cause the cancer itself. Secondary prevention is if someone has not did not get vaccinated but wants to know how to prevent this cancer. What does she do? Is early detection, which comes from her getting her pap smear every 3 years. And then if eventually we notice any abnormality, we move on further to do the colposcopy and the biopsy to know the stage she's in and know how to help her. Then the tertiary prevention is palliative care for people that have now eventually contracted this cervical cancer. This is now how you try to at least help them to see that they live out the remaining period of their lives, not being in a very painful condition. After all this, after all said and done, for the people that we are going to manage for this cancer, we follow them up. For some people, when they have cancer and you already offer them the surgery, give them the chemotherapy or the radiation, some of them will go. And afterwards, they will have a relapse, which means that they will come down again with the symptoms of the cancer, which means some part of it did not fully die then. So we have to keep on following them up to make sure that it does not come back again. In conclusion, we've spoken about this cancer, we've spoken about how it's gotten, we've talked about the risk factors associated with this particular cancer, we've spoken about the symptoms that will come with it. So the question now is, since we've already known all this, what should we do? What should be our take home from this presentation? It is that we ought to have personal lifestyle modification. For individuals that smoke, they have to reduce the level of their smoking. For people that have multiple sexual partners, it's advised that it be stopped and for them to have only one partner that they are going to be faithful to limit the spread. Effective screening is that once you're of age and you know you didn't get vaccinated as at when you're supposed to get vaccinated, one of the things to do is to make sure that when the time is due, you go get your vaccination, you go and get yourself screened to make sure that you don't have any lesion that is growing without you knowing. Prompt management is that you've gone, you've screened, and they've seen something. You don't start going to the church or to your pastor or to the lab to go and get medications to take or start looking for herbal things to drink so that all this will go. It's time you come to the hospital so that prompt and adequate action will be taken almost immediately. Government policies. This is the point where most people don't get vaccinated because of the financial responsibility concerning the vaccine. So the government can go a long way in helping by subsidizing the rate of these vaccines and trying to add it to the API vaccination card so that as soon as a child is born, they give her vaccination card. She knows that by the time she gets to 9, 10 years old, that she still has an outstanding vaccination to take, which is the HPV vaccine, so that it will prevent her from even contracting this virus in the first place. We believe that in doing this, it will help to curb the virus menace and reduce the morbidity and the mortality. Thank you so much for joining us today to listen to this. It's been our pleasure, and we hope that everything we've said, that you listened carefully and picked some useful tips from it. It's now time for questions. If you have any question from me, please come in and ask me. Thank you very much.
All right, thank you very much, Dr. Thank you for the wonderful presentation. So we have a couple of questions in our comment section. One from Ms. Jane Anatonia. She says, does it mean that all cervical cancer is solely caused by HPV? And then the second question says, how does prolonged use of oral contraceptive cause cervical cancer, even when women are screened negative for HPV? And there's another question, third question from a participant called Chinazo. Chinazo wants to know, she says, she kindly unpack prolonged use of contraceptive. Does contraceptives like implants and IUDs, IUCD have the same outcome as oral contraceptive? So that, Neka, you can react to these three questions while we are waiting for more questions.
Okay, thank you very much for these questions. It shows that we've been listening. So the first one was is all cervical cancer solely caused by HPV? 94 to 95% of cervical cancers have been shown to be caused by human papilloma virus, especially the ones that have the oncogenic strains of the 16 and 18. Of recent, there's another strain that was added, the strain 31, 32. And another thing is that for some people, when they have just HPV, they may not eventually go further to have this cervical cancer. Some of them would eventually still self retract. It will stop. It will just remit on its own. And it has also been shown that when people have HPV, in addition to some STDs, like an infection with chlamydia, trachomatis, or herpes simplex, that they stand a greater chance of having this cervical cancer than others. The second question is, how does prolonged use of COCP cause cervical cancer? Now, the prolonged use of the COCP, that's the combined oral contraceptive, the pill, the progesterone pill that has been taken. It's statistics that have shown that the mechanism of action by which this happens, when we've done some research, it has been shown that for some ladies that have been using these combined oral contraceptives, the rate at which they get cervical cancer when there's HPV infection too is greater than people that don't use it. The third one is prolonged use of COCP is not, is it also the same outcome with implants or IUCDs? No, it's not the same thing with the implants and the IUCDs. The kind of contraceptive that has been implicated is the combined oral contraceptive itself, not the other means of contraception. Thank you very much. I hope that answered your questions, please. Do we have more questions?
All right, thank you, Dr. Neka. Do not have any questions in the comment section.
Okay.
So,
Hello, I have a question.
Yes, please.
My name is Aditayo.
Yeah.
You talk about vaccination for
Yeah.
young ladies.
Yes.
Does it have any implications along the line by the time they will grow up and maybe get settled in life and will start to procreate?
Okay. Thank you very much for that question. No, it doesn't have any implication for them. Remember that we said vaccination is that you get the particular pathogen you want to prevent, but it's going to be tapered down in such a way that, excuse me, in such a way that the amount you give is just enough to cause an immune response, but not enough to give that person the particular infection itself. So it will just start building your antibodies in such a way that when the real thing comes, you have soldiers in your body that would fight it. So it's a natural response. It won't have anything that will prevent them from procreating later in life.
Thank you.
Thank you very much for it.
all right, thank you. We have a comment from Abdul Wahid. He said,
Yeah.
excellent presentation. My comments are that one, cervical cancer is a preventable cancer and it can be prevented. He also reiterated that oral contraceptive use can lead to high risk because oral contraceptives do not protect against sexually transmitted infection. And lastly, he says both male and females to be protected with vaccine. So thank you very much, Abdul Wahid.
Chapter.
And that's why I can't really understand this question. You said, what are the treatment options for her? The question is not clear. So can you resend the question in the comment section? So while we're waiting for a few more questions, please let's also be informed that this recording will be available to us and to be shared online on all our social media platforms for those who are unable to join us. Okay? All right, Dr. Neka, can you give us some closing remarks before we
Okay.
draw our curtains on this webinar
Uh,
session?
so thank you very much for listening in. It's been our pleasure to present this to you. This presentation is coming from eClinics and Diagnostics, and it's our own way of aligning with the global cervical cancer awareness. In our facility, we offer HPV vaccinations, we offer pap smear, and if there's any diagnosis made, we offer the services of consultant gynecologists that will eventually take up the management when needed. So we hope for the ladies, we hope that you know which category you fall into and do the needful. For the males, we know that we didn't really emphasize much on the males, but we know that males also help in the transmission. So part of the risk factors could serve as a deterrent for us, and we could equally get vaccinated. For the married ones, we could equally talk to our spouses, our mothers, our sisters, for them to get tested and also be enlightened about this. So thank you very much for joining us in this session. We hope to see you soon in our facility. Thank you.
All right, thank you very much, Dr. Neka. For all our participants who attended the webinar session, we say thank you and have a wonderful day.
Thank you very much.